when we do this differential assessment between autism and OCD, we're going to pick different interventions. OCD can get wiped out with behavioral interventions. Autism is going to persist. So we need to be really careful about doing a careful conceptualization and not rush through that phase into a treatment phase where we haven't really understood what the function of the behaviors that we're observing are.
In the world of mental health, understanding the unique experiences of neurodivergent individuals is crucial, especially when it comes to addressing anxiety and OCD. Can behavioral interventions like cognitive behavioral therapy, or CBT, coexist with neurodiversity-affirming practices? And how can understanding learned helplessness transform our approach to anxiety and OCD treatments? Joining us today is Dr. Jeremy Shuman, a neurodivergent psychologist specializing in these very topics. That's straight ahead on episode 199. I'm Emily Kircher-Morris, and this is the Neurodiversity Podcast.
What is neurodiversity?
You see the world differently.
Autism spectrum.
Gifted.
Complexities that are inherently inside.
ADHD.
Dysgraphia.
Tourette's.
All brains are different.
You are exactly what this world needs.
This is the
Neurodiversity
Podcast.
Just a heads up that if you missed the enrollment for the Neurodiversity University Educator Hub back in September, we are going to be opening it up for enrollment in the new year. If your New Year's resolution is to learn about creating a neurodiversity-affirming classroom for your students, you won't want to miss the conversation, the open office hours with me, and expert webinars that are included in the hub. Also, we continue to grow our library of resources that our members can share with their colleagues, like our 5-minute PD videos and one-page resources. If you want to be sure to catch all the info when registration opens back up, be sure to click the link in the show notes and get on the list. Okay, my conversation with Jeremy is up next.
Previously on the Neurodiversity Podcast.
A lot of people think that music in the background is a good thing for learning, or even other kind of background noise. The research shows, at least for neurotypical individuals, for sure, and I imagine the same would be true for neurodivergent individuals, but maybe it would be even heightened for them, is anytime there is language in whatever that background noise is, it can be highly distracting. Our brains are sort of hardwired to process language. So even if it's music, but there are words in the music, our brains automatically just pick up on that. And we are over there now paying attention to that music that has the words in it. But the same can be true about people talking in the background.
That's episode 187. Find it wherever you get your podcasts.
I'm happy to welcome Dr. Jeremy Shuman. Jeremy is a neurodivergent licensed psychologist who specializes in neurodiversity-affirming supports, especially related to anxiety and OCD. Jeremy, thank you so much for taking the time to join me today.
Thanks so much, Emily, for having me on your show.
So I love talking to neurodivergent clinicians because it brings an important perspective to the conversation that kind of blends both the expert plus lived experience pieces of the neurodiversity movement together. To start off the conversation, I'd love to hear you describe how you understand neurodiversity-affirming therapy and the goals that we hope to achieve with our clients.
Sure. That's a very big question. I'm going to zero in on some specific points that I like to make about what neurodiversity-affirming therapy is. Because I'm in the world of anxiety therapy, we're trying to help people overcome a lot of fear and hope that they get to a place where they're able to re-engage with things in their lives that they were avoiding or they were engaging with a lot of distress. And there's a lot of pressure from their community to be successful with this treatment. And so when I think of neurodiversity affirming therapy, I think of removing that pressure from the community, making sure that folks who are getting therapy are choosing their own goals, and that those goals have nothing to do with fundamentally changing who the person is, but more helping them to be flexible, So whereas there's a lot of grievances against neurodivergent people from their community, neurodivergent affirming therapy is not going to be addressing those grievances. It's going to be helping our client with their own individual goals so that they can have more flexibility. And that may address some of the grievances of their community, but we're doing that from the perspective of what the client wants, what they're individually interested in achieving.
When you refer to grievances, can you elaborate on that a little bit?
There's a lot of writing and talk in the neurodiversity community, specifically around autism, how the definition of autism is based on observations of autistic kids. And I love this analogy. So I'm a mandated reporter as a psychologist. If I suspect that there's abuse going on with a child that comes into my office, I have to report that. And I have to take these trainings all the time to make sure I'm up to date on what would be reportable or not. And there's a really classic example. So if a kid comes into my office for a first appointment and I start asking them about their hobbies and their family, and they won't sit face to face with me, and they're rocking back and forth, not making eye contact, and they can't talk to me at all about their family, I might think, this is a kid who's going through something. It's not normal to have no positive feelings about your family or your interests. It's not normal to not engage with me in this safe space where I'm a trusted adult potentially. Why are they rocking back and forth? There must be some abuse going on. And I would hotline that kid. I would say, I don't know what's going on, but I suspect that there's abuse going on because of these behaviors that I'm observing. But if that same kid gets dropped off by a parent and the parent says, oh, he's got problems with eye contact, he doesn't like to talk much, it's because he's autistic, I might have thought, not coming from the background that I come from, but if I don't know autism, I might have thought, oh, this is just normal autistic behavior. These are just autistic traits. But not making eye contact, rocking back and forth, avoiding talking, these are self-soothing strategies. These are coping strategies. If I see someone testifying in front of Congress, they have that same sort of bent over, they're rocking back and forth, they're not making as much eye contact because they're thinking, they're nervous. It is a coping strategy. And so we describe these autistic behaviors from the outside, what we see these kids doing when they struggle. And we describe that as the definition of autism, that there's these deficits in social ability because we want them to be more social. And there's these deficits in their restrictive repetitive behaviors because we want them to be more flexible. And these are grievances. It's not what autism feels like on the inside. So that's what I mean by grievances. And this is also true in the anxiety community. You're avoiding this. We need you to go to school. We need you to eat these foods because it's difficult on a caregiver or it's difficult on the support people. And that can be a big motivation for people to want to change. But we want people who are entering into therapy to think about what their own goals are and not just be responding to the grievances of their community.
I really appreciate that context with the coping skills. I think that's really important. And also another factor about what is neurodiversity affirming is recognizing that normalcy is not necessarily the goal. That's not necessarily the thing that we are looking for.
Absolutely. Yeah, that's what I call fundamental change intent of a therapy. I think neurodiversity affirming therapy is always going to avoid 3 pitfalls. The first is fundamental change intent, where we're saying who you fundamentally are has to change. You're going to become normal. As the result of this therapy, you will lose these neurological differences, which we know doesn't really happen. I mean, we're just able to be flexible. We're able to accommodate and maybe desensitize a bit, but we're not going to fundamentally change. The second one is it's not coercive. Neurodiversity affirming therapy can't be coercive in a sense where in order to get what you need to be regulated, you need to perform a compliance behavior first. Neurodiversity affirming therapy needs to make sure that folks have access to what they need in life to have a full life and to feel regulated and to feel okay. And so we can use coercion in a number of ways, like forcing exposure on people who aren't ready for it, withdrawing supports from people who need it without any sort of negotiation about a way that this can work out for everyone involved, making the person's environment pretty unbearable because they don't have access to, for example, like the stims that help them stay regulated, or their special interest that helps them feel like they have a solid identity, or that they're forced to be in a situation that's really overwhelming for them. And then maybe they can withdraw after that into a place of regulation and safety. We can't set up an expectation that you're only successful in therapy, you're only okay in the eyes of your caregivers if you've done this compliance behavior before you're ever going to get access to the things that make you feel okay. That would be very coercive, in my view.
Yeah.
And then the third point that we don't want to do is about this learned helplessness piece. And our goal of therapy is to help people actually become more resilient, or to desensitize to these stressors so they really have less distress, and not to just learn that there's no escape from the distress and their needs are never going to be met and they just have to deal with it and put up with it. That's not a good goal either.
I find as a clinician, sometimes I feel like I'm caught in this place where it is hard to balance those neurodiversity affirming practices with those behavioral interventions. And as you were kind of alluding to, obviously there's a reason that a lot of people in the neurodiversity community push back against behavioral strategies. But you also seem to recognize that there is a way to integrate those two. And, it sounds like it comes from a place of buy-in with clients and making sure that their goals are the ones that we're working towards. But can you tell us a little bit more about how you balance behavioral interventions or CBT strategies with that neurodiversity affirming perspective?
This is such a huge area of interest for me because I am trained. I have a doctoral degree in psychology. I was trained in CBT. I've practiced behaviorism for more than a decade, and it is my background. And I find it to be the most helpful for conceptualizing, and the most powerful interventions that I have are often behavioral interventions in terms of what actually starts change processes in people's lives. So I really love behaviorism. At the same time, I'm connected to the neurodivergent community, who a lot of times is very against behaviorism in general across all contexts, because they've had experiences or they've heard of people who are having experiences with these issues with fundamental change intent or coercion. And it was hard for me to reconcile this at first, but my experience working with neurodivergent clients and doing behaviorism has shown me that it is absolutely possible to take agency of your clients into account and to not be coercive as we do this, and that there are extremes on either side of this bell curve, where on one side we have behaviorists who say it's impossible to traumatize the client in the course of exposure therapy, which I don't believe that to be true. And then on the other side of the aisle, we have people saying no autistic people should ever do behavioral therapy because it's always going to be traumatic. And so I find the first side to be really naive and poor conceptualization. And I find the second side, I use the term guardrailing. It's like saying, oh, you can't go to college. That's going to be too difficult for you. For someone who thinks that they have the ability to do that, but they've struggled with executive function. We have to let people live up to their potential, let people engage with the materials in the world that they want to. And behaviorism is such a powerful intervention. We should not guardrail people away from it through discouragement and a one-sided argument about it. We should present the whole gamut of how behaviorism works and let people choose that for themselves if they want to. So after people have chosen this for themselves, we're not guardrailing away, then we're going to want to make sure to do a really good conceptualization. There's so much of the behaviorism world that is sort of siloed into the anxiety camp. They don't know so much about autism. And the differential assessment between autism and OCD is a pretty tricky one, because OCD is all about repetitive behaviors with compulsions, and autism has all these repetitive behaviors that are highly regulating. A lot of them are like put in positive sensory input so that I can feel okay with the bombardment of aversive sensory input in my environment. When we see people doing these repetitive behaviors who are autistic, who are getting joy out of it and who are connecting with an identity out of it and who are feeling more regulated out of it, we might still see their support system having grievance about this, about how they're not flexible, how they're taking time, how they're not efficient, how things aren't going the way they want, how they can be controlling about ways that things happen in their space. And a clinician who's a behaviorist in the anxiety world who doesn't know autism might hear, oh, this is a person who has anxiety about change. This is a person who has anxiety about this overwhelming sensory experience. And so they might jump in with an exposure therapy trying to get this client to desensitize to something when this was never going to desensitize. This was going to be something where we had to negotiate some accommodations. We might learn some more flexibility and distress tolerance, but we're not trying to ask the client to always be distressed with it. So when we do this differential assessment between autism and OCD, we're going to pick different interventions. OCD can get wiped out with behavioral interventions. Autism is going to persist. So we need to be really careful about doing a careful conceptualization and not rush through that phase into a treatment phase where we haven't really understood what the function of the behaviors that we're observing are. Because we might have grievance about something that is really important to that person, and we might choose to be flexible about our expectations of that person as well.
Yeah, I love that. And you kind of alluded to this a little bit when you're talking about that conceptualization and understanding some of the functions of things. I think sometimes people may hear the term functional assessment used by clinicians, but it's not always easily understood. But it sounds like that is kind of a piece of this. Can you describe what a functional assessment is and how it's used and the benefits of this type of a process?
Yes. Functional assessment in general just means we're trying to understand why did the person do this behavior. And in a most basic sense, we might look at what came right before that behavior and then what came after this behavior. And we're looking for what antecedents and consequences are of a particular behavior. And then from there, we can say what reinforces that behavior or what discourages that behavior. And in a simple way, we could just look at, if I want to get this person to perform a certain behavior, if I add stuff before or add stuff after, or take away stuff before or take away stuff after, they're more or less likely to perform that behavior. And in a simple way, that's very helpful. And we can actually do a lot of helpful behavior change with these sort of simple functional analyses. But a more complex functional analysis is going to ask about things like emotion. It's going to ask about subjective experiences of what this distress feels like that may have led to this behavior that we're observing. So when we're doing a functional assessment between OCD and autism, we're looking for things like the person with OCD is saying, oh, I don't want to be doing this behavior, but it's necessary or I'm going to feel so awful. And the person with autism is saying, this behavior is part of who I am. I like doing this behavior. It makes me feel good. And that's a big difference. I'm imagining someone who's got like a not just right experience with OCD, and they are touching a certain texture until it feels right, and they can't move on from it. And every time they touch that texture, it sends them into distress because they're not getting the feeling they want, and they're repeating it over and over again, and they're telling their family about how awful it is that they're stuck in this loop. People are trying to help them, and they're melting down and having issues with their family. The person with autism might be touching that same texture, but might be enjoying it every single time they touch it. And it's not the same thing. They're not stuck in a loop where this texture really is giving them nothing, and they're just doing it out of a fear that's a false alarm. It has actually got an important function in keeping them happy and regulated. And by engaging with it, they're doing a positive thing in their life. So when we ask, how is this working for you? Why are you doing it? We can understand beyond just diagnoses and into where do we want to do an intervention? Because I want to do an intervention for the person who's tortured by the repetitive behavior, but there's no intervention for the person who likes their repetitive behavior. The intervention might be more of a social intervention about negotiating ability to interact with their stims with the people who are complaining about it.
I think it also, of course, gets complicated when you have the layering of, say, autism and OCD. That can be, again, very tricky.
Definitely.
But it's important to kind of at least look at those pieces to try to figure it out. It reminds me of a client that I've worked with in the past who was having some OCD types of thoughts and behaviors surrounding contamination, germs specifically. But this person was also autistic. And when asked about it, it did seem like there were some negative effects in their day-to-day life, but also it was calming for them. It kind of had both of those aspects. How would you approach that with a client? Is there a way that you would tease that out to see maybe what the next steps would be?
Yes, and this is getting into more specific therapy stuff, but I would help the client really understand what OCD is. OCD is about a doubt about something that you already know. Your five senses have detected something, your sense of self knows something about your identity, and you're saying, what if something that I haven't seen yet is actually more important than everything I already know? And that experience can be catalyzed by autistic difference. That is to say that ways that autistic people differ from the neuromajority create these confusing experiences for autistic people. Why is everyone like this when I'm like this? And I don't have an explanation for it. And I can come up with a scary story that explains this difference. Not accurately, not saying, well, we're just wired a bit different. This is just subjectively different for me. But coming up with a story that adds in details from the person's learning from the past, the narrative that has accumulated over their life about this content, and they can end up forming an obsessional doubt from these differences between their traits and the traits of the neuromajority. So I help people to understand what this doubt is, and then they can cleave apart this compulsion that is just responding to some scary story in their head that they no longer believe in versus the regulating behavior that is repetitive in the same sort of way. But absolutely, that repetitive behavior that was once pleasurable can be hijacked by OCD and start to have a different function that relieves distress about some obsessional doubt. But we can burst that doubt bubble and they can continue on engaging with that behavior in a way that no longer is motivated by the false alarm of OCD.
That was such a good description. I appreciate that.
I would like to actually plug here, there is exposure and response prevention is our gold standard intervention for OCD, but that is a behavioral intervention. And folks don't know that there are non-behavioral evidence-based interventions for OCD. Really, the two biggest ones are inference-based cognitive behavioral therapy and then metacognitive therapy for OCD. Neither of those really has a prolonged exposure component to it. So those might be more tolerable for folks who are averse to exposure to begin with. But the language I was using about discerning obsessional doubt and being able to see that in contrast to other parts of your cognition, that comes straight out of the inference-based cognitive behavioral therapy. And I'm betting that many of your listeners would not have heard of this because it's pretty new to the US. It's more popular in Canada, but it's only maybe a year and a half that it's been widely distributed in the US.
Yeah, that actually leads right into what I wanted to ask you about next was exposure-based interventions, which we've kind of talked about. And so then you're saying there's this inference. Tell me again the names of them with the non-exposure-based interventions.
So the one with the most evidence-based that's not exposure and response prevention is inference-based cognitive behavioral therapy. It comes from Fred Ardema, who's working out of McGill, and the late Kieran O'Connor, who was his partner in research. They are constantly churning out papers to provide the evidence base for this. Our designation of an empirically supported treatment comes out of the American Psychological Association Division 12. And we are trying to get together. We have a non-inferiority trial that shows that it's no worse than ERP. And then we're going to add that to a meta-analysis and send that off to Division 12. And fingers crossed that we'll get that evidence empirically supported treatment designation sometime in the next few years.
Awesome. This is something you're involved with as well?
Yeah, I've been in the OCD world for a while, and I tend to gravitate towards people who are thinking outside the box. And so I gravitated towards this a couple of years back, and I was part of the group that trained clinicians in the US on it, and I'm a consultant for, we call it ICBT. So I do consultations for folks who are in this intersection.
I'm curious also, you alluded to this earlier in one of your responses, talking about learned helplessness and recognizing that occasionally, and I think this maybe has to do with those guardrails that you were talking about, that we might prevent somebody from accessing supports that perhaps might help them. But I would love for you to talk a little bit about how learned helplessness is a factor in treatment, especially when we're working with neurodivergent clients, and what we really need to understand to help clients avoid developing learned helplessness.
Yes, this is so crucially important to me. And the folks that I train, this is a point that I'm going to make so certain and clear. And it's a little bit of a spiel here, and it's a little bit of professional jargon, but I'm just going to go for it and hope that your audience appreciates some of the background on this. So I do this type of anxiety therapy where you have to go face your fear, and then you have learning experiences that show you that you didn't have to be avoiding it to begin with. No bad outcome happened when we faced it, and then I feel better on the other side. And there's a lot of models that explain why that works as a therapy strategy. And for the longest time, we used a habituation model. Habituation means that if I am exposed to a stimulus and I want to give a response to that stimulus, if I'm exposed to that stimulus enough times, I'll stop giving that response to that stimulus. And in a most basic sense, it comes out of research with like sea slugs. This is a great way to describe it. Sea slugs have these little eye stalks, and fish will eat them if they see their eye stalks. So when there's any sort of threat, they pull the eye stalks back into their body. And when things are calm, they stick the eye stalks out. So we get a sea slug, it's got his eye stalks out. We zap it with a little electric current. It senses danger, so it pulls the eye stalks back in. Maybe 30 minutes later, it sticks the eye stalks back out. We zap it again. It pulls the eye stalks back in. This time, it only takes 20 minutes for him to stick the eye stalks out. We zap him again. That time gets shorter and shorter and shorter until he just leaves his eye stalks out and says, this zap doesn't really mean threat. He's habituated to the stimulus of the zap, and he no longer is going to perform the behavior of pulling his eye stalks back in. But sea slugs are not people. They don't really experience distress. They don't really have learning that is so logical and linear the way that humans do. So what might this look like if we were trying to apply this model to a human being? Well, most of us have had an experience where we habituated. It's summer and you're going to a pool and you're going to go get in the pool, but you dip your toe in and you find, oh, it's really cold in the water today. I kind of don't want to get in. My behavioral response to this is like, I would like to avoid, but I get in the water anyway. And at first it's uncomfortable and I'd love to get out of the water, but I stay in it anyway. And after 10 minutes, now the water's not uncomfortable. It's just cold and I can have fun in here. I desensitized to the cold and then I habituated my response of wanting to flee. I feel fine now. So the cold feeling might remain, but the distress desensitized. Now I'm habituated to this cold and this is a great outcome because I want to stay in the water. I'm actually enjoying myself. I have lower distress. So that seems like a good model also. If I sit with a distressing feeling for enough time, I'm going to habituate to it. I'm going to lower my distress. But habituation is not the exact same thing as desensitization. That cold pool analogy, I desensitized to the cold. And so I get a good result out of it because my distress lowers. And so I can face this fear, this discomfort now, because it is literally easier because it is less intense. And so we've done this exposure therapy model for a long time where we expose someone to something that they're fearful of. We watch their distress rise, and then we say, you have to sit with this feeling, sit with it long enough that the amount of distress you feel cuts in half. And if you feel better after you've sat with this for enough time, then this is going to help you feel better overall. This was a great model. We had a lot of success with it. Actually, OCD was considered untreatable up until like the 50s or 60s. And now that we understand this learning model, OCD becomes treatable. It's wonderful. Mm-hmm. But then in the 2000s, Michelle Krask at UCLA was doing some research on this mechanism of action and trying to see how do we optimize the kind of exposure therapy that we do? How low do we need to see distress go before we're going to get this benefit? And what she found was that reduction of distress when doing exposure therapy in like a single trial did not mean that it was going to be any easier next time you show up to my clinic and you have to start this all over again. A week later, that distress was back up to the ceiling again. What did help reduce distress is when we would bring that anxiety level up, we bring that distress level up, and then we'd have this moment of recognizing, okay, I can handle this, but we don't necessarily wait for the distress to come all the way down. we go back towards the stimulus, we re-trigger ourselves, and we have that learning moment again and again. That it wasn't the reduction in distress that predicted an overall good outcome. It was frequency of these moments where your expectation got violated. You thought it was going to be awful, but then it was okay. Putting a bunch of those moments together, that actually had better results in her studies than watching this distress rating go severely down through one trial. And so she came up with some hypotheses about what really explains this. And this is the inhibitory learning idea. And it's saying that maybe even if distress doesn't reduce, we have these learning experiences about what's happening here. I'm building a new mental model for what happens when I engage with this distressing stimulus. Now I expect I'm going to feel bad, but my feared outcome isn't going to happen. The scary story I was telling myself doesn't come true when I face this. I feel scared anyway, but I have confidence that the scary story isn't going to come true. And also, my resilience for this distress is much better now that I have some practice facing it. So my willingness to go face this stimulus at the drop of a hat, without much warning, without presentation, that can increase over time through this repeated expectancy violation. So now she would encourage folks that when we're doing our therapy, we don't care if our patient reports reduced anxiety, reduced distress during an exposure therapy session. What we care about is increased willingness and increased confidence that the feared result won't happen. And this was really helpful for anxiety therapists because we had a number of patients that were getting better even though their distress wasn't reducing during their in-person exposure sessions that we were doing. They were still finding that over time they were getting better. So we had a different explanatory model for it. And also clients would come in and say, my distress stayed high. Aren't I supposed to desensitize to this? And we could say, well, if you are getting more of your life back, if you're living your values, if you're able to flexibly face these things, then you've had a great outcome for this, even if your distress didn't reduce. And this was really helpful. This was very affirming to a lot of clients. But let's take this to the furthest extreme and talk about Martin Seligman's study with dogs that gives us our term learned helplessness. So he hooks these dogs up to a contraption where a light will flash and then they get zapped and there's no escape from it and they can see the light and they will struggle, but just nothing is going to help them to actually escape from the pain that they're going to receive. So at first they're struggling whenever they see the light, but then eventually they learn the light means I'm going to get zapped. There's no escape. And they just lay there and take it. And the dogs start to look depressed because they're learning they are helpless. There's nothing that they could do to escape. And then Seligman takes those dogs and he puts them into a box where one side of the box has an electric grid on the floor that'll zap them, and the other side of the box has no electric grid and they'll be safe. And there's a little divider that the dogs were going to have to hop over to escape. And he flashes a light just like they saw before. And do the dogs try to escape? No, they learned, I just have to take it. So even though the escape was now available to them, they stopped trying for it. And this is what can happen when we rely so much on that inhibitory learning model. I think in truth, inhibitory learning is saying that I feel so much more confident that my feared outcome isn't going to happen. So I am in the process of reducing distress about this. It's not the only way that we will inhibit the behaviors through learning. We also can learn, I'm such a problem when I display these behaviors. No one will ever accept me if I have these behaviors. No one will ever accept me if this is my identity. So I've learned that there's no hope if I want to display these parts of myself. There's no hope for me to feel regulated. There's no hope for me to feel anything less than a high level of distress every day of my life. And the people around me, they don't have to feel that distress because they're not bad like me. My neurology makes me different, and that makes me the one who has to change because difference is bad. And I've learned that no one is going to accept this. So let's just keep all this internal. Let's make my disability as invisible as possible so it doesn't inconvenience anyone. And let's make my distress as invisible as possible so no one accuses me of being a complainer. And then what happens is the therapist has this client fill out an outcome measure and they got nothing to complain about on the outcome measure. And the therapist gives himself a huge pat on the back and says, look at the results I get with this client. no longer doing their compulsions, no longer annoying their family, not reporting distress anymore, but internally, that client is losing their sense of identity, losing their sense of agency, losing any sort of self-esteem that said that they deserve to feel pleasure and happiness and positive feelings about their identity. And that is a completely unacceptable outcome for me. And where we see these neurodivergent folks who are complaining about behaviorism, it's because they've had outcomes like that, where their therapist and their parents are patting themselves on the back for how successful this treatment was. But in the client's individual subjective experience, all they learned is that they're unacceptable and it's hopeless that they'll ever be able to experience pleasure in life. That's what I mean by learned helplessness that we can teach people.
Yeah, I feel like that's a really good way to kind of frame that and help people kind of understand and recognize how that's aligned with masking and camouflaging and all of these things that don't increase a person's sense of agency, a sense that they can be a change agent in their own lives.
Exactly.
Jeremy, I am so grateful for your time today. As we wrap up, I wanted to ask you one last question. If you had a new client who is coming in and they are neurodivergent, but they're dealing with a lot of anxiety or OCD, and they have perhaps this sense of learned helplessness, and they're just trying to figure out what they might be able to do, what is it that you would say to them? What is the one thing that you would really want them to hear as they are trying to figure out if this is a step that they're ready to take?
The one message I'm giving all of these clients is you can trust yourself. These clients have experienced a message that they can't trust their sense of the world, and this contributes so much to OCD and so much to distress, and it's such a difficult process to be able to regain that trust in self, especially for our neurodivergent clients who actually struggle with interoception and maybe don't always have the best data to go by, but they still have the data, and everyone else's data about them is not going to be as accurate as what they're feeling on the inside. So the message is going to be about recognizing sources of outsourcing your sense of self, outsourcing your sense of agency, and then learning to trust yourself again instead of relying on those external sources of truth.
Dr. Jeremy Shuman, licensed psychologist at the Center for Mindfulness and CBT in St. Louis. Thank you so much for taking the time to talk to me today.
Thanks so much, Emily. It was fun.
The overlap of sensory needs, obsessive-compulsive thinking, and anxiety can be difficult to tease out for neurodivergent people. But it is so important to recognize that there are strategies that are useful. I worry sometimes that clinicians, but also parents and educators, are ruling out certain interventions that can indeed be neurodiversity-affirming in the correct context. We need to be on the lookout for neurodivergent people who've given up on even trying to improve their anxiety or other circumstances because their needs have been ignored for so long. They assume there is no other option than to deal with the experience. I'm encouraged by the research that Dr. Shuman is doing on how to integrate these tools into neurodiversity-affirming frameworks, and I'm hopeful that we'll have more professionals who will continue to integrate them into their work. I'm Emily Kircher-Morris. I'll see you next time on the Neurodiversity Podcast.
Thanks again to Jeremy Shuman for spending some time with us today. There are links to his work, including one to his OCD seminar coming up in the spring of 2024. Also, I am really excited about our new Educator Hub. If you're a teacher, administrator, or anyone really involved with education, we're building a really helpful gathering place. In fact, it's already underway, where you can learn and share ideas about giving your learners the best experience that you can. There is a link so you can get notified as soon as enrollment opens again, and you won't have long to wait. Our host is Emily Kircher-Morris. Our office manager and social media director is Krista Brown. I'm the executive producer, Dave Morris. For all of us, thanks for listening. and we'll see you next time. This is a service of the Neurodiversity Alliance.